to be by sharing knowledge and getting that knowledge from people who know the most about what they're talking about. And that's why we have Dr. Zacks here today. He's an expert in carcinoid heart disease, and he's affiliated with Mount Sinai in New York, and he also has, I forgot the exact title of it, the Carcinoid Heart Center. He'll talk more about carcinoid heart disease than I'm going to be able to say, but it is one of the hidden things about our disease. A lot of people only learn about carcinoid heart disease when they're diagnosed with it. And as we all know, it's a very scary diagnosis. That's why we're bringing Dr. Zacks here today, so that way you can learn about it and hopefully prevent it from happening. So without anything more to say, if Dr. Zacks could step up. Yes, thank you.
Okay, good. So my thanks to what's now going to be CACNETS and also to NCAN and to those who were the prime movers in both of these organizations. And I had a chance to speak with Ralph Lemming a bit about B. And this all started from B asking two questions. Why can't we be proactive about searching for accurate knowledge about our disease? And the second question was, why can't we be proactive about educating our care providers about our disease? And that's all it really got started, by asking two important questions. So as you know, Bea was the founder and previous capital area carcinoid survivors president. And she had this unwavering commitment to educating people about neuroendocrine tumors. And what I read about her is that you honor her by holding these lectures featuring experts. I'm not sure how I got included there. By holding lectures by people most knowledgeable about our disease. I think Bea was ahead of the curve. So I have one disclosure, and that's I'm on the advisory board of Lexicon, which is the manufacturer of Zermello. And I just want to make a comment about this board membership that I'm participating in. When I heard about Zermello being developed, my one comment was, I'm hoping that this is the drug which will put me out of business. Because theoretically, if you're able to halt serotonin production, you can halt or prevent carcinoid heart disease. It hasn't been proven in a controlled study, but theoretically, it seemed to me to be a possibility. The former chief of cardiac surgery at Mount Sinai, my good friend Robert Litwak, said, there's nothing worse than a person who doesn't know what he doesn't know. And Lawrence Peter said it differently. A man doesn't know what he knows until he knows what he doesn't know. Well, I know what I don't know, and it's depressing. So I have a few biases. I'm going to get a little closer so I can see my nose. The published statistics for the incidence of carcinoid heart disease is an underestimate. Murmurs are often not heard. Right heart failure is often attributed to other causes. Echocardiogram often not performed in neuroendocrine patients. the reported 4 to 5% incidence of net metastases into the heart is an underestimate due to the failure to image systematically for extent of disease, and the gallium-68 PET CT scan will probably solve this problem. The biomarkers chosen for monitoring neuroendocrine tumors are often not the most sensitive and specific for neuroendocrine tumors. It's because some people are not up to date, and inertia prevents change. So here's the roadmap. We're going to start out talking about neuroendocrine tumors because you can't talk about carcinoid heart disease without putting it into its context. And so my goal is to make it clinically relevant. We're going to give some definitions: carcinoid, carcinoid syndrome, carcinoid crisis, functional versus non-functional neuroendocrine tumors. Some of this has already been covered well already. Biomarkers, they're evolving, but inertia prevents more rapid acceptance. Epidemiology, orphan heart disease categorization may end soon, but is that a good thing? Controversy, shall we agree to get rid of carcinoid in favor of neuroendocrine tumor? Etiology of carcinoid heart disease, serotonin and its receptors. Pathoanatomy of carcinoid heart disease, characteristic plaque and scarring. Treatment decisions, how to treat, timing of procedures. Major problems, delay in diagnosis. You've already heard about this. And the lack of knowledge of management options and protocols, and physicians lacking enough hands to manage this multifaceted disease. Serotonin, guilty but not alone, supposed to promote health. Serotonin is a normal substance in the human body, has good functions, but if it's overproduced, it's creating problems. Carcinoid heart disease, diagnosis, surveillance, treatment, and it's about people, patients, families, and your care team. Carcinoid, well-differentiated neuroendocrine tumors, they represent less than 2% of all malignancies. They are originating from the enterochromaffin cells of the body from head to pelvis. 22 to 27% come from lung, 62 to 67% from primary nets in the GI tract. Foregut, that's the mouth to the duodenum at the entrance to the bile duct, including thymus, lung, and pancreas. And Ed Wolin has told us, how could it be that you include those others? It's because of the embryonic origin. Midgut, 26% of neuroendocrine tumors are from the end of the foregut, including 2/3 of the transverse colon. And the hindgut, distal third of the transverse colon to the rectum. Because they were originally noted to be slow-growing, they were initially thought to be carcinoma-like, but benign. Currently, all are considered to be malignant, but they are graded on the basis of their aggressiveness as measured by their mitotic or proliferative index and Ki-67 staining, grades 1 to 4. Grades 1 to 3 are neuroendocrine neoplasms. High-end grade 3 and grade 4 are neuroendocrine carcinomas. There's some repetition here, but I don't think repetition hurts. The controversy, carcinoid versus neuroendocrine tumor. It's not a new controversy. The pathologist Siegfried Oberndorfer in the early 20th century termed what he saw under the microscope carcinoid or carcinoma-like, but he thought they were benign. This was an error. And you talk about this renaming it neuroendocrine tumors. As early as 1928, Gossett and Mason characterized carcinoids as neuroendocrine tumors on the basis of amine uptake and decarboxylation properties. Be aware of the rationale to use neuroendocrine tumor versus carcinoid, but beware of the fervor to shun those who continue to refer to midgut neuroendocrine tumors as carcinoids. Carcinoid syndrome, flushing. Unlike the moist flush post-menopause, it's typically a diffuse, dry, hot feeling with marked redness of the skin. Diarrhea. It's secretory, not frothy or floating. The frothy, floating type represents fatty stools, whereas this is a secretory, highly watery diarrhea. It's an effect of the normally helpful serotonin, but with the dial turned up to max. Bronchoconstriction, wheezing, often confused with asthma or chronic lung disease, and fibrosis, retroperitoneal, abdominal, and my focus, carcinoid, cardiac, which causes the carcinoid heart disease. The cause, tumor, either GI or lung, synthesis and release of polypeptides, prostaglandins, and vasoactive amines. Substances such as bradykinin, tachykinins, including substance P, and neurokinins, histamine, serotonin, and others produced by these neuroendocrine tumors. Carcinoid crisis. This is extreme flushing, diarrhea, wheezing, and or marked fluctuation of blood pressure, either too high or too low, including shock. It's important to anticipate it, recognize it, and treat it. And later, I'm going to go over the protocol for preventing it if someone has to undergo an invasive procedure. Functional versus non-functional. This is repetition. Functional is a tumor which secretes substances which create symptoms. And non-functional neuroendocrine tumor is a tumor which does not secrete symptom-causing substances. By definition, a tumor which causes a carcinoid syndrome is a functional neuroendocrine tumor. Non-functional neuroendocrine tumors are often not discovered until they produce symptoms, not from the release of vasoactive substances, but by the physical effects created by increasing growth of the tumor. The evolution of biomarkers. Chromogranin A is no longer considered an accurate marker, even though there's a whole body of literature on the use of the chromogranin A test. Fortunately, somebody figured out that if you measure its breakdown product, pancreastatin, it is unaffected by so many of the things that throw off your chromogranin A. And so pancreastatin has been shown by at least 3 major groups in the US to be more sensitive and specific than chromogranin A. And we use the the pancreastatin test. Sometimes I'll do both, but I always include the pancreastatin test when I'm following a neuroendocrine tumor patient, especially if the baseline is abnormal. Urinary 5-HIAA has given way to the use of plasma testing for 5-HIAA or blood serotonin. I'm not going to go into the debate about the fluctuating levels of serotonin, only to say that for many years I have tested blood serotonin and have found it to be an extraordinarily stable, useful marker to follow in my patients. And in those studies that I've presented at national meetings, I've always shown the values, and they have proven to be very reliable. I think if you want to get another opinion, you should speak directly with Ed Wolin. The urinary 5-HIAA test is only a problem in its collection. It's a 24-hour collection. It's difficult for patients to do an accurate collection, and they have to be on a low amine diet prior to the collection. So I personally no longer order the 24-hour urine 5-HIAA test. Grading, not staging. Most of the patients have stage 4. So I'm not going to go into this in detail, but only to tell you that the pathologists have given us so much knowledge about this. The grading is so important, but it's kind of complex also. And so tumors fall into one of the following 3 grades: well-differentiated low grade, grade 1. Grade 2, well-differentiated intermediate grade, grade 2, and grade 3, poorly differentiated high grade. This is an oversimplification. Under WHO grading scheme, pulmonary and thymic tumors fall into one of the following 3 grades. The European Society for Medical Oncology, ESMO, uses only mitotic count for bronchial and thymus tumors for determining tumor grade. And then this is a whole big list. NCCN guidelines, 8th edition of the American Joint Committee on Cancer's AJCC Cancer Staging Manual, ESMO guidelines, TNM classification, the ENETS and 2010 WHO guidelines, the Study of Adrenal Tumors guidelines, the UK and Ireland NETS guidelines. They have all dealt with the grading system. So it's a little bit detailed, and it's worth looking into for your individual type of neuroendocrine tumor. So in 2013, NANETS concluded that while the criteria differ among the various classification systems, the underlying data are similar, and pathology reports should include notation of the systems and parameters used to assign the grade and stage. Mitotic index and Ki-67 vary in different sites within the same tumor and in different metastases in the same patient and in biopsies in the same patient over time. A bit about epidemiology. The incidence of NETs from early 1970s until 2017 increased from 10 to 70 per million per year in the USA. In Sweden, it was 84 per million per year. And the prevalence, that's different from incidence, the prevalence in the United States, as recently as we have information, which is up through, I believe, 2017, is 170,000 patients at this time in the U.S. An orphan disease is a rare disease or condition that affects fewer than 2,000 people in the U.S. Beware the loss of orphan status, because funding and the development of drugs is driven by neuroendocrine tumor orphan status. So while we sometimes say, oh, it's rapidly progressing incidence in the United States, I'm a little bit worried if it gets up near that 200,000 for our population. The etiology of carcinoid heart disease was studied in an experimental guinea pig model in 1964 by Maria Spatz. And she found that for carcinoid heart lesions to develop, you needed 3 things: a high serotonin, some liver damage, and relative tryptophan deficiency. Now, if you think about it, the high serotonin and the tryptophan deficiency go hand in hand. It's because tryptophan is the building block of serotonin. And so that's why you have tryptophan deficiency when you have a high serotonin. Serotonin in high concentration travels from metastases in the liver via the inferior vena cava to the right side of the heart. Serotonin stimulates serotonin receptors on the inner lining of the heart, causing fibroblast proliferation. That simply means scarring. The two right heart valves, the tricuspid and pulmonic valves, become deformed, and the inner lining of the right heart is scarred. Serotonin, carried mostly in platelets, is deactivated in the lungs, thereby sparing the left heart valves, the aortic and mitral. If there are involvements of left heart valves, you must search for the cause. Either a patent foramen ovale, which is a hole in the heart, allowing the blood to get over to the left side without going through the lungs, or a bronchial carcinoid producing serotonin, or an extremely high serotonin level, which overpowers the lungs' capability of deactivating serotonin. There is an exception to this concept of a liver full of mets producing serotonin and causing carcinoid heart disease. We have seen a number of patients with no liver involvement whatsoever. But if you see that pattern, you have to explain it. And the exception is ovarian carcinoid, because the blood draining from the ovarian carcinoid can have a high concentration of serotonin, which bypasses the liver and goes directly into the right heart. As many as 70% of patients with carcinoid syndrome may develop carcinoid heart disease during the course of their disease. It's driven by the high serotonin. Serotonin stimulates fibroblast proliferation, predominantly on the right side of the heart, affecting the tricuspid and pulmonic valves. The negative impacts are right heart failure, so the patients tend to have fatigue, edema, and if that edema rises up to the level of the abdomen, they develop ascites, bowel edema, which causes malabsorption, and if it continues to rise and is not diagnosed appropriately, patients develop pleural and pericardial effusions. It results in poor quality of life, increased risk of mortality. The 5-year survival in patients with small intestinal nets is 71% in patients without carcinoid heart disease, 37% in patients with carcinoid heart disease. The median survival for net patients with carcinoid heart disease is 1.6 to 4.6 years. That's without treatment. The pathoanatomy, this simply shows a cut through the heart at the level of the 4 valves, the mitral valve, tricuspid valve, aortic valve, and pulmonic valve. The tricuspid valve and pulmonic valves are your right heart valves. This is the pathoanatomy of carcinoid heart disease with the characteristic findings taken from a patient of ours who underwent replacement of tricuspid and pulmonic valves. And this is the fixed fish mouth type appearance of a valve which is no longer pliable. It's thickened, fixed, it doesn't open properly and it doesn't close properly. And below that fish mouth, you see a right a white plaque. That is typical carcinoid plaque formation. It's fibrotic material caused by scarring due to high serotonin. And this is the same valve, and they used an instrument for purposes of demonstrating what that valve would look like if it were closed. And so they pulled it into the closed position. These are two echocardiographic images which show a diseased tricuspid valve. And since you're not looking at these images every day, you have to take my word for it that these are supposed to be very thin, pliable valve leaflets which go open and closed. And this is a phase where it's supposed to be closed. It's thickened, shortened, and not closed. And this shows a Doppler image with the blue showing blood flow through a valve which is no longer closed. So is the incidence increasing or decreasing, the incidence of carcinoid heart disease? Carcinoid heart disease occurs in 40 to 70% of cases of carcinoid syndrome. Some argue that the frequency is diminishing due to recent therapeutic advances, and I believe it's simply underdiagnosed due to the failure to search for or recognize it. 4 to 5% of carcinoid syndrome patients have actual, not just carcinoid heart disease, but actual metastasis into the heart. But could this percentage actually be higher? I don't have the answer to that, but my own bias from looking at patients who are sent for echocardiograms and who are imaged with gallium-68 scans is that you will see that the incidence is probably higher than 4 to 5%. The gallium-68 PET-CT already suggests it, and we've simply failed to search for cardiac neuroendocrine tumor metastases. Treatment decisions. Patient with a midgut neuroendocrine tumor, mets in the liver, and carcinoid heart disease. Which problem to fix first? The primary tumor is usually in the terminal ileum, often tiny. You must define the extent of disease with the extent of carcinoid heart disease with a transthoracic echo. And you must control heart failure as your first initial steps. Then you repeat the echo to determine the inferior vena cava pressure status. If the pressure is normal, it's safe to perform tumor reductive procedures prior to heart surgery. If the inferior vena cava pressure is high, the liver is congested, and bleeding risk is high, you must fix the heart first. So making this decision is actually fairly straightforward on solid grounds, and you can tell whether the liver is under a high pressure from the heart valve problem or not, and you can tell which you can do first. Do tumor reduction or fix the heart. This detailed slide is what I actually write for the protocol for protecting the patient through surgery. I'll go through it quickly so that you have an idea of what you need if you have carcinoid syndrome. So this is for people who are about to undergo cardiac catheterization, surgical procedures, or other invasive procedures. The most important number one thing is to schedule the procedure within the first 2 weeks of the most recent monthly LAR or lanreotide injection. That is most important. For prevention or treatment of carcinoid crisis, during or after invasive procedures, start an octreotide IV drip at 100 micrograms per hour at least 2 hours pre-procedure, and continue it post-procedure for 24 to 48 hours or until the patient is stable. They may not need it after the procedure. To inhibit tumor release of bradykinin, give 100 milligrams of Solu-Cortef IV on call to the cath lab or the operating room. For signs or symptoms of a carcinoid crisis, flushing, diarrhea, wheezing, and or extreme increase or decrease of blood pressure, give an extra 100 microgram bolus of octreotide and increase the drip to 200 micrograms per hour. For persistence or recurrence of a crisis, give an extra bolus of Solu-Cortef and repeat the bolus of octreotide and turn the drip up to 300 micrograms per hour, and you repeat this as often as necessary. We've gone as high as 500 micrograms per hour without significant adverse effects, and others have used even much higher dosing. For a hypotensive crisis or shock, give copious IV fluids, extra 100 microgram octreotide IV bolus, and increase the drip by another 100 micrograms per hour. Give extra Solu-Cortef, 100 milligrams, and give vasopressin intravenously. Avoid the administration of adrenergic pressures, such as epinephrine. They stimulate tumor release of vasoactive amines, and also avoid anesthetics and pain medications which cause adrenergic stimulation. A word about giving the Solu-Cortef. By reducing the release of bradykinin, you reduce the tendency to have shock. Bradykinin is a potent vasodilator which drops the blood pressure to shock levels. And I write that I remain available by telephone during the procedure, and I give my office number and my mobile number so that the team knows they always have contact with someone. Treatment of carcinoid valve disease. We have to make a decision. If they need valve replacement, should we use a mechanical prosthetic valve or a bioprosthetic tissue valve? Now, the neuroendocrine tumor experts prefer that we use tissue valves because there's less likelihood that the patient will require the anticoagulant Coumadin on a long-term basis. On the other hand, there is the risk of recurrence of carcinoid heart disease on these newly implanted tissue valves. And up until the last couple of years, the incidence of recurrence, we reported on 27 patients, there was a 46% recurrence rate. 2 of those patients had to have a reoperation, and at that time they elected to have mechanical valves. However, now we have a substance, a drug, which can block recurrence by reducing serotonin. I reported on 2 patients, it's just anecdotal, both were heading to the OR. One had recurrence on bioprosthetic valves and the other was developing carcinoid heart disease, and this was 3 years ago. They have both avoided surgery because we have halted the progression of disease with the use of Zermello. So let's pause before the next slide to see if we can agree upon abandoning the use of the term carcinoid in favor of the term neuroendocrine tumor. All in favor signify raising your hand that you would prefer that we abandon carcinoid and go to neuroendocrine tumor. Okay, now those opposed? A couple, okay. Early recurrence of carcinoid valvulopathy after valve replacement. This was the origin, the paper which told the high incidence, 46% of carcinoid heart disease recurrence soon after valve replacement. Median time was 16 months, attributable to a failure to reduce serotonin to normal levels after putting in tissue valves. Of the 27 patients reported, 26 failed to get their serotonin down to normal. Only one, after tumor reductive procedures and everything else, achieved a normal serotonin level. High levels of chromogranin A on follow-up were found to be the only significant predictor for recurrence. A multidisciplinary approach is mandatory to control tumor activity, reduce biomarkers, and make the critical decisions concerning valve prosthesis selection. At that time, before Zermelo, our recommendation was consider mechanical prosthetic valves in this challenging setting. On February 28th, 2017, the US FDA approved Zermelo in combination with somatostatin analog therapy for the treatment of adults with carcinoid syndrome diarrhea that somatostatin analog therapy alone has inadequately controlled. Now just remember, I think the majority of us gave up the use of carcinoid. So now we're talking about neuroendocrine tumors. None of you are eligible for the use of Zermelo because it's only approved for carcinoid syndrome diarrhea. So remember what you asked for and consider all aspects before you make a rapid change. But in view of the fact that it was first suggested in, I think it was 1928, I'm not all that optimistic that we're going to make a complete change to neuroendocrine tumor. Telocrostat. Since that paper of 2014, the FDA approved the first pill which inhibits tryptophan hydroxylase, the first step in the production of serotonin from the essential amino acid tryptophan, and the drug does not cross the blood-brain barrier. Therefore, it's not plagued with a high incidence of depression. This is a game changer with the potential to put me out of business because of the potential to prevent carcinoid heart disease or halt its progression once it is diagnosed. How are we on time? How are we on time? Just, if anyone has a cane, just come and when my time is up. Okay. Case report, 2 patients, which I presented at ENETS in 2016. The conclusions: carcinoid heart disease is a frequent complication of the carcinoid syndrome. Telocrostat reduces serotonin to levels which appear subthreshold to that which stimulates fibrosis associated with carcinoid heart disease. This drug might prevent the need for valve surgery in many cases and enable the use of bioprosthetic valves in others without recurrent fibrosis. So a review of the percent reduction of 5-HIAA. Thank you very much. Okay, so a review of percent reduction of 5-HIAA or serotonin in 5 carcinoid heart disease patients from the Telestar and Telecast trials revealed a 47 to 90% reduction of these markers from their pre-telotropstat levels. So that's really encouraging. What about the 46% recurrence after replacement of valves using bioprosthetic tissue valves? So now if you've had bioprosthetic valves put in and you still get a recurrence, it used to be that we would recommend a reoperation. And now we had our first patient who had recurrence. She was a little bit unstable going into surgery, so we did not proceed with surgery. We elected the next day to do a transcatheter tricuspid valve-in valve replacement of the tricuspid valve, preventing the need for a reoperation. And this is the current approach to recurrent disease on bioprosthetic valves. I want to show you this case that was recently referred to me by Ed Wolin. It was a case in which there were no preceding cardiac symptoms, with the exception of fainting, several episodes of fainting. Otherwise, no heart failure, no heart murmur detected. So the patient was sent over to me with instructions to do an echocardiogram. No consultation, just an echo. Because I had been admonishing the team, get a baseline echo in all your neuroendocrine tumor patients. So Ed sent the patient over. And this is what we found. If you can run this video. Okay, let's try the next one. Can that one run? So let me just tell you that the red is blood flow, which is supposed to extend from here up to here. Notice that it's limited right about here. Something is preventing the blood from reaching the full right ventricular outflow tract right beneath the pulmonic valve. And now, can you see this mass? That is not supposed to be. You're supposed to have black there, which represents a cavity, the right ventricular outflow cavity, right below the pulmonic valve. When my echocardiographic colleague in our office, our technician, called me into the room, he said, "There's something strange here." And he showed me that mass. This patient had a right ventricular free wall moving mobile mass right beneath the pulmonic valve. If it had broken off, it would have occluded the pulmonic valve and the patient would have died. I'm assuming that this one won't run either. Once again, this is the mass. All the pictures are the same mass. Again, right ventricular outflow tract, there's a density there that's abnormal. Way up at the top, a mass. Again, that density is the mass. So this patient went to surgery. And this is a photograph taken at the time of surgery, and this is the mass being removed. The patient did very well. He had episodes of carcinoid crisis, which we treated with octreotide. He was discharged home on postoperative day 10. And at the time of discharge, an echocardiogram revealed a normal echo with right ventricular, left ventricular, right atrial, left atrial size and function normal, no mass, no pericardial effusion. He had some thickening of the mitral and tricuspid and aortic leaflets, but no real carcinoid heart disease, no regurgitation, and no stenosis of the valves. He's doing well, and they are now directing therapy at his neuroendocrine tumor in the abdomen. So, is there a role for transthoracic echo and or BNP surveillance in carcinoid heart disease? So I'm just going to answer this by saying that the transthoracic echo is the only test which is 100% accurate in diagnosing the presence or absence of carcinoid heart disease. And the reason why I included BNP in here is that blood levels of NT-proBNP, which is a break-off fraction of BNP, or BNP, are good markers for carcinoid heart disease. And what it represents is the stretching of the right side of the heart, which leads to the release from the myocardium of this substance which tries to correct for heart failure. And it turns out that it's almost considered a poor man's echocardiogram because it has a high chance of telling the presence or absence of significant carcinoid heart disease. The only comment I have is that early fibrosis and early effects of serotonin on the valves are likely to be diagnosed with a transthoracic echo than waiting until you have right heart failure. So let me just say that for carcinoid syndrome patients, BNP and NT-proBNP are both sensitive and specific for carcinoid heart disease. So the question is there something more appropriate than NT-proBNP in judging the pressure effect of right heart failure on the liver? And the answer is the transthoracic echo assessment of the inferior vena cava shows its size and respiratory variation. And that focuses upon the pressure within the liver. A review of 3 studies concluded that the assessment of systemic venous congestion still requires clinical scores of congestion inferior vena cava derived ultrasound indices, and circulating levels of BNP or pro-BNP. What about the frequency of doing an echo? For patients with a diagnosis of carcinoid heart disease, surveillance echo should be performed annually. That was the statement out of ENETS in 2008. And I think this is an oversimplification and under certain circumstances incorrect, because the rate of progression of carcinoid heart disease is extremely variable depending upon the level of serotonin and other factors in patients who receive bioprosthetic valve replacements. Recurrence of carcinoid valvulopathy, even of mild degree, has been noted as early as 3 to 4 months after valve replacement. So because of the variable rate of progression, a patient-specific surveillance interval of 3 to 12 months would seem more appropriate. Is there a role for echo and BNP surveillance with certain 5-HIAA levels? Again, it has to be individualized. So this year, we asked the question, has it been shown that high levels of serotonin contribute to mortality? And so we did a retrospective analysis. Our search identified 1,715 records, of which 12 studies, including 755 patients, 3,442 person years with 376 deaths, were eligible for the meta-analysis. Across all studies, the mean 5-HIAA was 149. Normal is 9. Mortality was 13%. The meta-regression equation showed that for every 10-unit increase in urinary 5-HIAA, there is an 11.8% increase in 1-year mortality. That's the relationship. Thank you very much. That's the relationship between serotonin and mortality. We're hopeful that the FDA will take that into consideration when we recommend the use of telotrestat for controlling serotonin. So our study suggests that the serotonin measured by its urinary 5-HIAA is predictable of 1-year mortality in patients with neuroendocrine tumors. These findings highlight the importance of reducing non-cancer related morbidity and mortality among these patients. Telotrestat, is there a role? Telestar trial, 12-week study period, randomized, controlled, 135 patients with 4 or more bowel movements per day, showed that telotrestat, attacking the first step in the pathway of serotonin synthesis, it showed whether or not it would be effective, and it looked at 2 dosing schedules, 250 TID, and then everyone was increased. Well, and half the people were on 500 TID. At the end of that first 12 weeks, it was extended 36 more weeks, and everyone was given 500 TID. 5-HIAA was reduced by 40% in the lower dose group and 58% in the higher dose group. So, who are candidates for Telotrestat? In the absence of a randomized controlled study of Telotrestat in carcinoid heart disease, the following recommendations are based upon Telestar data as well as clinical and anecdotal observations. All patients with carcinoid syndrome, a 24-hour urine 5-HIAA above 300 micromoles, or plasma 5-HIAA elevation, despite optimal doses of somatostatin analogs, in all patients with an echocardiographic evidence of carcinoid heart disease would be candidates for Telotrestat treatment, starting at a dose of 250 TID and increasing to 500 TID if serotonin markers remain above normal. So I just want to remind you that the FDA approval is for treatment of carcinoid syndrome diarrhea in adult patients suboptimally controlled with somatostatin analog or those intolerant of somatostatin analogs, LAR versus lanreotide. I just want to make a couple of comments. Lanreotide is a subcutaneous injection. Sandostatin LAR is an intramuscular injection. There is a problem. You have to mix the LAR prior to injection. And if it's not done properly, you can get a non-injection. You can get clogging of the syringe and you will not get the medication deployed. And the patient may not realize it. And so lanreotide is premixed and is not fraught with that issue. So in summary, is there a role for an echo? Definitely yes. What about echo and BNP? I think yes. Frequency we talked about. Telotrestat we talked about. There's an appropriate role. And who should be treated? Those with elevated serotonin-related syndrome and or carcinoid heart disease. So major problems. Just quickly, you know all of this. Delay in diagnosis. There's this ongoing effort to teach. That's why I'm here today. The lack of knowledge of management options and protocols. We need centers of excellence. Physicians lacking enough hands to manage this multifaceted disease. You need a team approach with a net expert as its leader or coordinator. And the team must collaborate with patients' local care team. That's very important. Dick Warner and Ed Wolin have always approached neuroendocrine tumors in agreement that it must be a team approach, a collaboration among net experts of multiple disciplines, their support staffs, families of net patients, always with the patient sitting front and center in the driver's seat. This is just our group. You'll see Dick Warner and Ed Wolin as our leaders. Dick has retired and Ed is our leader. And he's a wonderful leader. Thank you.